In this lecture, we're going to cover EKG and cardiac rhythms. When you are placing a patient on a cardiac monitor, there are different systems that use 3 leads versus 5 leads. So these are pictures. The one on the left is going to be the 3 lead, as well as the one on the right that is going to be 5 lead. To try to memorize these, if you can remember that white is right, and that there is grass under clouds. There is smoke over on the left top, over fire, which is the red, and then brown is just slightly off of the sternum to one side. As far as the 3 lead, again, it is going to be white is right, and then smoke over fire. When a patient is a cardiac patient, or we're trying to evaluate their rhythms, we're going to order a test called an EKG or an ECG. This is going to be various angles of the heart, and we have to put on the appropriate wires in certain places. You're going to have one on each arm, not on a bony prominence, and then one on each leg, and again over in the meaty part of your shin, not over a bone. And then V1 is going to be on the right side of the sternum at the 4th intercostal space. V2 is located on the left at the same level of the 4th intercostal space. And then the other ones, lead 3, 4, 5, and 6, are going to be placed at very specific intervals. V6 is going to basically be at the mid-axillary line, and you can see here at the level of the one that you can see over on the far right. The EKG can be utilized to see if there is any areas of ischemia or infarcts for the patient, and it will also tell us what cardiac rhythm they're in. When we're looking at an EKG, you can see here that red area, that is the P wave. The P wave, anytime you see that, you know that the impulse is coming from the sinoatrial node that is located up in the atria. So if the pulse is being generated, the impulse is being generated from that, you will see the P wave. The yellow measures the point that is the PR interval, and that's the length of time that it takes for the impulse to start at the SA node and actually move through the atria. So that would be, when we are measuring it on an EKG strip, it should be 0.12 to 0.20. The next area that you see here is going to be the QRS, and that is depicted by the blue bar, the aqua colored bar. That is going to be where the pulse is generated, the amount of time that it takes for the impulse to move from the AV node into the ventricle and to be actually conducted as a heartbeat. When we're measuring this, it should be 0.06 to 0.10. Anything that is longer than that is called a wide QRS. We do not want to give calcium channel blockers to somebody who has a wide QRS, because basically what it'll do is it will delay the conduction through the AV node, and your QRS will become even wider. The next segment is depicted with the purple line, and that is called the ST segment. The ST segment normally should be flat and at baseline like this. When it is elevated, that is called an ST elevation MI. So that is the point that we're going to be looking to see whether or not that is angled upwards. The navy blue is the T wave of the heart. That is the resting period of the heart, and that if a premature ventricular contraction occurs during the resting phase of the heart, it can actually send the heart into ventricular tachycardia, or it will send them into ventricular fibrillation. So if you do have a beat that is occurring within the T wave, it is absolutely imperative that you are going to notify the doctor. The green one is the QT interval, and again, certain medications will actually prolong that QT interval and send them into some different types of rhythms also. When you take a look at a rhythm strip, this one is going to be called a normal sinus rhythm. You do have a P wave before every single QRS, and that the QRS intervals from one to the other are very normal and regular. In this sense, we can take a look at the QRSs, count them, times it by 10, and that will be the approximate heart rate of this patient. So go ahead and count the QRS complexes. And you should have had 7, so times 10, this patient's heart rate is going to be approximately 70. So again, that does constitute a normal sinus rhythm because you have a P wave and the rate is between 60 and 100. Now by comparison here, you can see that this rate is so much slower. And that this one, you do have a P wave before every single QRS, but the rate is extremely slow. This one is going to be called sinus bradycardia because the heart rate is actually less than 60. If we count the number of QRSs here, you'll see that we have 3 of them times 10, so your heart rate is actually down into the 30s. I want you to take a look here because you do have the P wave before every single QRS, but you can see that you have a lot more QRS, so you want to count that. And you should get 13. You're going to times it by 10, and that this patient is going to have a heart rate of about 130. Supraventricular tachycardia is going to be different than ventricular tachycardia because supraventricular tachycardia means above the ventricles. So this is going to be something that is going to be occurring, but it is above the level of the ventricles. Sometimes we can have paroxysmal supraventricular tachycardia where it just kind of comes on and off. But again, the patient should probably have a very, very hard pounding in their chest. They certainly should understand that their heart rate is not normal. This one, if you count the number of QRS complexes, see what you get. You would get probably actually, you're going to have 9 of them, but you can see that up at the very, very top, there's a little mark up on the white, and then there's a mark more on the right. From that mark to this mark, that is a 3-second strip. So what we're looking at is a 3-second strip. So where you're counting about 9 QRSs, if it was a 6-second strip, your rate would really be about 180, and that is definitely too fast. Now here you can see on the top you have a normal sinus rhythm versus an atrial fibrillation. Atrial fibrillation has no discernible P wave. It is a slow, like a wavy type of a line right here. The other characteristic about atrial fibrillation is it's always going to be an irregular rhythm. Now here's another strip that you can see, and you can take a look at your QRSs and see that they're all very, very different. So your rate is not a regular rate. It is, let's see, 1, 2, 3, 4, 5, 6, 7. It's at a rate of 70, So this would be called more of a chronic atrial fibrillation. If atrial fibrillation had a ventricular rate of up in the 100s, like 130, 150, that would be called atrial fibrillation with a rapid ventricular response. Now you can see here there is a difference in the look of atrial fibrillation and atrial flutter. Basically, what you have to understand is that those rates are going to be at about a rate of 300 to 350 impulses up in the atria itself. Now, we are finding out more things now as we're doing more electrophysiology, but what we had thought previously to all of these EP studies that we're doing is that atrial fibrillation comes out of the left atria and that there is a left atrial appendage. And in that appendage is where you have the stasis of blood that would get shot out and render the patient at a high risk for stroke. Typically what we thought before is that if you had atrial flutter that was coming from the right atria. So we are actually finding a lot more literature, a lot more things that are going on, and I just wanted to point those out to you. Now here you can see up at the very top you have premature ventricular contractions, and all of those are circled in the picture on the left, so they look very, very different. They look wide, they look aberrant. The ones right next to them are a nice normal narrow QRS, so you can see the difference. And then again, over on the right-hand side, you can see the difference between what was a normal QRS and what is a premature ventricular contraction. The picture on the bottom represents ventricular tachycardia. Now you can have short runs of ventricular tachycardia where you have a normal sinus rhythm. It'll go into a short burst of maybe a 10 beat of ventricular tachycardia, and then it breaks again and goes into a normal sinus rhythm. This one here is ventricular tachycardia, and it has not gone and changed at all. So ventricular tachycardia will go into ventricular fibrillation. It's just a matter of time. But basically right here the ventricles are beating so quickly that there is really no perfusion that is getting out to the person's system. Third degree heart block, I just want to point out this. You can see that you have a lot more P's, but that the P's are not always followed at the appropriate time by a QRS complex. So again, you can see your QRS to QRS, that is totally a regular rhythm. And if you're taking a look and you're doing P to P, you're going to see that that is a regular rhythm also, but that there is no connection between atrial and ventricular. This is a heart block that does require a pacemaker. And again here, this one just depicts where you have the ventricular tachycardia. There is an impulse down in the heart that is generating this irritability, and it is the irritability that is going to cause, again, VTAC. Sustained runs of VTAC will go into VFib. And then here you can see that this is just kind of a chaotic, very, very disorganized, no pattern, and that the ventricles in the heart are just fibrillating. Your patient basically is dead right here because they are not going and effectively ejecting any blood for a cardiac output. So again, you cannot hurt a patient here because the patient basically is dead. What we have to do is we have to stop this rhythm with defibrillation. And defibrillation is usually the only thing that will change and get the pattern to a normal sinus rhythm. So are you going to call a rapid response or a code blue? So rapid response came up probably about maybe about oh, it's been over 10 years ago, but what we determined is that the patients who deteriorated, they actually had been deteriorating for about 8 hours before they actually coded. And the people weren't really recognizing those subtle changes in the vital signs and some of the key things that they really needed to. So here we can go and call a rapid response, and we will get a critical care nurse who is very used to working with very, very critically sick patients. They are going to be another set of eyes, another assessment to see whether or not your patient has a reason to be transferred to the intensive care, or if they have a reason for some other types of therapy. Code blue is going to be actually when the patient does arrest, whether they have a cardiac arrest or whether they have a respiratory arrest.
Attention please, code STEMI ER. Attention please, code STEMI ER.